So the question was,
How long does it last?
how long does the side effects last after chemotherapy? So the side effects usually begin about the 3rd to 5th day after chemotherapy, and they last for about 2 weeks. And usually by the time you're ready to get your next treatment at 3 weeks, you feel fine. It is a cumulative effect though. So after a couple of treatments, you're going to see more neutropenia, you're going to see more anemia, you're going to see more nausea, fatigue, because it's a cumulative effect. But the most is between day 3, about day 15.
How many rounds of chemotherapy do you usually require?
Okay, how many rounds of chemotherapy is required? Typically, you're going to give 2 treatments of chemotherapy, and you're going to repeat staging. You're going to repeat either a CAT scan or a PET CT to see if that chemotherapy is working, because you don't want to continue something that's not working.
You mentioned how important diet is. What is a recommended diet?
Lots of protein, high protein. If you're going to eat a lot of junk food, make sure it's high protein junk food. You know, some patients actually have very poor diets when they come in to be diagnosed. And I tell them to eat high protein and good nutrition, fruits, vegetables, whole grains, and they look at me like I have 2 heads because they've never eaten that way in their life. But the patients that do eat well do better.
I had a question about the staging. Are they still using staging as widespread as they used to? And, isn't it different from institution to institution how they look at the staging?
The staging, the question is staging, is it different from institution to institution, and is it still currently used? It is used. It's a good tool to decide treatment planning and to give a patient a prognosis. It's a good tool, but basically if you have resectable disease that surgery can remove, that's the way to go, and that's the most important takeaway from staging. Is it resectable or is it non-resectable? Those are the 2 things you need to do to decide how this can be treated or not.
Do any patients have chemo and then have the EPP?
Yes, that's the induction, do patients have chemotherapy and then have EPP done? The induction chemotherapy, that's before an EPP or before any radiation, that's undergoing clinical trials right now.
And are you using that at MD Anderson?
Yes. We currently have 1 clinical trial with induction chemotherapy followed by surgery, followed by radiation.
Because chemotherapy, surgery, radiation.
Yes, and the chemotherapy is a targeted therapy as the induction. Yes,
I have a question. It's going to be a 2-part question.
Okay.
Do you ever use the drug Avastin at MD Anderson? And my second part to the question is, do you use the treatment where they use talc inside the cavity? Or I'm not sure the procedure, but using talc.
So the question is, do we use Avastin for mesothelioma? Avastin's not indicated for mesothelioma at this time. And the second question was talc in mesothelioma. We use talc when patients have large pleural effusions or a lot of fluid in their lung cavity, and we don't use the talc a lot. We don't like to use the talc a lot because it can prevent somebody from having a good surgical repair. Obviously, if somebody keeps accumulating a lot of fluid in their pleural cavity and they keep having progressive shortness of breath, it's difficult not to do the talc because it does help prevent accumulation of the fluid. But if you think somebody has limited disease, I would recommend not going for the talc because it may limit their surgical options. If you already know someone's extended stage and unresectable, then the talc is an excellent idea. Yes.
What percentage of patients that you've seen in your practice are candidates for resection?
What percentage of patients that I've seen that are resectable? I'm going to say probably about 3/4 are considered resectable. And then they have to go through the staging process and make sure their lung function is good and make sure their cardiac status is good. But you'd be surprised how many limited stage are discovered.
Can you talk about any other risks of chemotherapy as well as it relates to mesothelioma, and how you do a risk-benefit analysis of it too?
Okay, the risk-benefit for chemotherapy is always going back to the patient's performance status. If somebody's in bed most of the time, not able to eat well, drink well, very limited activity, chemotherapy is going to be very hard on that person. So you have to do a risk-benefit analysis to decide whether it's really worthwhile potentially making this person feel worse, because we're not trying to give chemotherapy to make somebody feel worse. We're trying to make them, in the end, to feel better. And sometimes the risk of chemotherapy is too high, and you decide not to offer chemotherapy.
And how do you discuss, when you talk to a patient, how do you discuss that with them, or how do you give them their options?
Are you asking how I find out a performance status on somebody?
No, how do you tell them, how do you decide whether, when you discuss it with them, how do you let them know how it's going to affect their quality of life?
Usually I always start out by telling patients that they will have the bone marrow suppression. That's going to be their biggest problem with the chemotherapy, which in turn will cause them to have the anemia, which in turn causes them to have fatigue. So I usually say that fatigue is the biggest factor, because the patients may not know that their bone marrow is suppressed and their white cells are going down, their red cells are going down, but they're going to feel the fatigue from that. That's what's going on. And fatigue can be limiting for a lot of patients, especially if they're elderly already.